All right, let's dive right in. Today's explainer takes us on a really fascinating clinical journey through pediatric skin conditions. We're going to start right at the surface looking at environmental injuries, specifically sunburn, and then we're going to travel much deeper. We'll explore systemic immune-mediated responses with psoriasis, and then finally unpack the deep hormonal pathophysiology and some seriously high-stakes medication management for severe acne.
So here's our agenda for today. 1. Sunburn, prevention and protection. 2. Psoriasis, the immune response. 3. Psoriasis, types and treatments. 4. Acne, pathophysiology and grading. And 5. Tretinoin versus isotretinoin, safety. But before we get into the first section, I want to hook you with a quick question. What does severe sunburns and severe acne actually have in common? I mean, at first glance, absolutely nothing, right? One is an environmental radiation burn, and the other is this hormonal bacterial condition. But the answer to this actually lies in a highly tested set of safety rules that we're going to uncover a little bit later. So just keep that question in the back of your mind.
Okay, moving to Section 1, Sunburn, Prevention and Protection.
Now, obviously, severe thermal burn management is a massive topic, but we cover that in a completely different explainer. Today, our clinical priority is strictly prevention teaching. And what's really interesting here is how practical these guidelines actually are. When we're educating families, the goal is never ever to just lock kids inside. We absolutely want to promote healthy outdoor play. The key is preparation. We teach parents to seek shade, use protective clothing, and a huge point to emphasize is avoiding direct sun between 10 and 1400 hours. Basically, peak heat. Sunscreen is essential, but it has to be reapplied after water play or sweating. And finally, always do a quick skin inspection after they've been outside. Again, we want kids playing outdoors. We just need them doing it safely.
Now here is a massive, heavily tested distinction from our source material that you absolutely cannot afford to miss. For general pediatric sunburn prevention, the standard teaching is to use at least SPF 15. Simple enough, right? But if a child or adolescent is taking a photosensitizing medication, things like certain oral antibiotics or isotretinoin for acne, that rule drastically changes. For those clients, the requirement jumps to an SPF of 30 or greater. It's a very specific wording flag you'll see a lot. General prevention is SPF 15, medication protection is SPF 30 or greater. Definitely lock that one in your memory.
All right, Section 2, Psoriasis, the immune response. Let's look beneath the surface.
To understand why psoriasis looks the way it does, we have to look at what I like to call the psoriasis domino effect. It's a chronic inflammatory disorder. The exact cause is still a bit of a mystery, but we know for sure it involves both the innate and adaptive immune systems. So here's the sequence. First, some sort of trigger activates the immune system. Second, this leads to inflammation and epidermal hypertrophy. Third, we get this wildly accelerated, excessive proliferation of keratinocytes. Those are your skin cells. And fourth, because this massive cell production completely outpaces the body's normal shedding cycle, the cells literally just pile up on the skin's surface. That surface accumulation is what forms those thick, visible plaques. So it's not a surface irritation at all, it's an immune-mediated overproduction.
Moving right along to Section 3, Psoriasis, Types and Treatments.
Not all psoriasis looks the same, and identifying the specific type is absolutely crucial. Let's compare the two major pediatric presentations. First up is chronic plaque psoriasis. This is the most common one in kids. You're looking for round, bright red plaques covered with thick gray or white scales, usually showing up symmetrically on the knees, elbows, scalp, and face. But then we have guttate psoriasis. This is often the very first way psoriasis presents in a child. Instead of those large plaques, you'll see small, scaly, round red papules. And here is a truly fascinating clinical pearl. Guttate psoriasis is heavily associated with a recent group A streptococcal infection. So a kid gets strep throat, and shortly after, boom, they erupt in these small red papules. It's an incredible clinical link.
When it comes to treating this, it's really a step-by-step, individualized approach. We always start with the basics, applying unscented moisturizers right after bathing to lock in moisture and calm that intense itching. Next step up would be topical corticosteroids to bring down the inflammation. If it's more severe, providers might use ultraviolet light therapy or phototherapy. And for the most severe cases, we bring out the systemic medications like methotrexate or etanercept. But hey, anytime you see meds like methotrexate, a huge alarm bell should ring in your head. These require incredibly strict, specialist-directed monitoring. We're talking rheumatology or dermatology getting involved.
Okay, let's shift gears to Section 4, Acne, Pathophysiology and Grading. Now, a lot of people think of acne as just a simple teenage rite of passage, something that eventually clears up on its own. But we absolutely cannot ignore the massive psychosocial impact it has on self-esteem and body image. To effectively treat it, we really need to understand the hormonal root cause. So let's trace it. Step 1. It all starts with hormones, specifically increased androgen activity, peaking right during puberty. Step 2. Those androgens signal your glands to pump out extra sebum, which is oil, and extra keratin. Step 3. All that excess oil and skin cell debris gets trapped, creating a follicular obstruction. That's exactly how your comedones or whiteheads and blackheads are formed. Finally, step 4. The follicle ruptures, and a bacteria called Cutibacterium acnes rushes in, triggering massive inflammation. Literally one biological step directly trapping the next.
Clinically, we map this progression out into 4 grades of acne, and you can kind of think of them as stacking on top of each other. Grade 1 is mild, just your basic open blackheads and closed whiteheads. Grade 2 is moderate, so you have the comedones from grade 1, but now we're adding inflammatory papules. Grade 3 is severe, everything from before plus pustules. And finally, grade 4 is cystic. This is the most severe form, adding deep, painful nodules and cysts into the mix. It really helps to visualize it as this escalating addition of lesions.
Which brings us to the climax of our explainer. Section 5. Tretinoin versus isotretinoin safety. Once a patient hits grade 3 or grade 4 acne, the treatments become extremely serious. And the distinction between these two medications is one of the most highly tested and clinically vital concepts out there. You have to keep them separated in your head. Tretinoin is a topical retinoid cream. The education here is simple but specific. Wait a bit after washing the face, use just a pea-sized amount, and apply it strictly at night because it causes photosensitivity. Isotretinoin, though, that is a completely different beast. It's a powerful, oral, systemic medication. It is strictly reserved for severe, refractory acne that has failed absolutely everything else. You do not hand this out casually.
Because isotretinoin is so incredibly powerful, I want to issue a priority alert right here. The safety guidelines and monitoring rules for a patient on this medication are incredibly strict. You have to know these cold because a mistake here can literally have life-altering consequences for your patient.
To help you permanently cement these safety concerns, our source material has a great memory device. When you see isotretinoin, I want you to think ISO, Intense Safety Observation. This intense observation focuses squarely on 2 critical pillars. First, psychiatric monitoring. You have to consistently assess the patient's mood and screen for suicidal ideation. Second, pregnancy prevention. Isotretinoin is highly teratogenic, meaning it causes severe birth defects. So we aren't just talking about a mild stomachache here. These are major, intense safety concerns.
Because of those huge teratogenic risks, patients in the U.S. have to be enrolled in the super strict iPledge program. If applicable, they have to use 2 mandatory forms of contraception, and the timeline is crucial here, starting 1 month before, continuing during, and for 1 month after treatment. Providers also have to routinely monitor liver function and lipid levels, specifically cholesterol and triglycerides. There's that continuous psychiatric assessment for suicidal ideation we just mentioned. And hey, remember our question from the very beginning of the explainer? Isotretinoin is highly photosensitizing, so this is exactly where that rule comes back. The patient is required to use sunscreen of SPF 30 or greater, not just the standard SPF 15. Lastly, you've got to monitor for severe dryness of the skin and eyes.
So as we wrap up on this final slide, here's a provocative thought I want to leave you with. Could the most dangerous part of treating severe skin lesions actually be missing a moods assessment? Just think about that for a second. We started today looking at sunburns and surface-level skin plaques. But by the time we reached the treatment for severe acne, our priority had shifted entirely to assessing suicidal ideation, protecting the liver, and preventing birth defects. I think it perfectly illustrates just how profound systemic treatments really are. It proves that pediatric dermatology is far, far more than just skin deep. Thanks so much for joining me on this explainer, and I'll catch you in the next one.